Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN, Healthy World, Healthy Nation, Healthy You. I'm Nancy Valentine, PhD and registered nurse, and this show is dedicated to you, the healthcare consumer. And today we have a very interesting topic that will be very much of interest to parents, mothers, fathers about their children with diabetes. So the title of our show today is Parent Alert, what you need to know about diabetes in children, and factors that can get in the way of recognizing symptoms. And our guest today is a national and internationally well-known nurse who is an expert in this field, Dr. Terry Lippman, and I'm going to introduce her. Terry is a Philadelphia native. She got her undergraduate degree at Temple University and her graduate degrees at the University of Pennsylvania, where she resides now. Dr. Lippman is the Miriam Sterl Endowed Term Professor of Nutrition, Professor of Nursing of Children at the University of Pennsylvania School of Nursing. She is also the Associate Program Director of their Pediatric Acute Care Nurse Practitioner Program, and she also is a practicing nurse. She practices as a nurse practitioner in the Division of Endocrinology and Diabetes in Children's Hospital of Philadelphia, #1 in the United States for children's care. So we are very, very happy to have Terry because she has published more than 100 journal articles, book chapters, and monographs, and has spoken widely to audiences nationally and internationally. So Terry, it's a pleasure to welcome you to our show today and to have an expert like you educate us about this important problem.
Well, thank you so much. It's a pleasure to be here with you, and it's a pleasure to be able to talk to everyone who's watching and be able to discuss this topic that's so important, diabetes in children.
Thank you. Now, Terry is going to be really educating us about the signs and the symptoms of this very, very serious problem. And she's going to be talking about how difficult it can be to really pick up these symptoms early on, especially in very young children. And then she's going to be helping us to understand the barriers to getting care, how we can really facilitate getting care more rapidly. And she's going to be talking about her diabetes registry, which I will save that because that is a cutting edge program that she put together 25 years ago and is really making a difference for people in Philadelphia. We're also going to be talking about racial disparities. That means inequality in terms of treatment between whites and non-whites. And she's going to be educating us a bit about that so that we can, again, be more mindful of making sure that everyone gets the same treatment. So our 3 key points that you're going to be taking away from this show today will be how to really understand particularly type 1 diabetes, and she will tell us the difference between type 1 and type 2 in children. And she will be telling us about the good diabetes control tactics, what you can do, so you'll have that to take away. And then the other thing is, and not to be underestimated, are all the age-related challenges in dealing with children with diabetes. It's not easy for parents, and we're going to help you find those pathways to success. So with that as an introduction, Terry, why don't we start with just, some basic understanding of diabetes. We hear a lot about diabetes, but you're going to tell us more about the science of diabetes. There's type 1 and there's type 2, and they even they're being named and understood differently than maybe a lot of people have heard different names. So start from the beginning.
So the easiest way to start is to differentiate between type 1 and type 2 diabetes. Type 1 diabetes used to be called juvenile diabetes because we generally saw it begin in childhood. It's now called type 1 diabetes. It's insulin-dependent diabetes. It's an autoimmune disease, which means the body attacks the cells that make insulin. We don't know why that happens, but that is what happens. The body attacks the cells. Children who have type 1 diabetes are dependent on injected insulin for life. So they can never take pills. That's some confusion, that sometimes it's a child. If you have type 1 diabetes, you can become older and take pills. That's never the case. As far as science knows now, you're dependent on injected insulin for life. Type 2 diabetes, used to be called adult onset diabetes, has gotten a lot of press in the past few years because we're now seeing this diagnosis in children, and it's because of the tremendous rise in obesity. So type 2 diabetes is associated with obesity and lifestyle factors. Inactivity, excess caloric intake, obesity are all linked to type 2 diabetes, and type 2 diabetes is now being seen in children. When I first began in working with children with diabetes, I never saw children that had type 2 diabetes. Type 2 diabetes was a disease of adults, and now I'm seeing type 2 diabetes in children as well.
Right. So I think from what I'm understanding from this so far, and again, I just want to go over it because that's a lot of information. So type 1 diabetes could be something that you inherit, or we don't even know what those factors may be, where a child winds up with type 1. But that's very different than type 2, which is really more environmental. It really it's more associated, as you say, with obesity and maybe other factors of lifestyle that children are being exposed to earlier on. So in terms of type 1 diabetes, how often do we see people that really come at a very early age with type 1 diabetes?
Okay, so if I could just back up for a minute, both type 1 and type 2 diabetes have genetic components.
Okay.
So type 1 diabetes has genetic components. Type 2 diabetes has strongly genetic components. What's different about the two is that if you know you're genetically predisposed to type 1 diabetes, in terms of what science knows now, there is nothing that we can do to prevent type 1 diabetes. Mm-hmm. If you know that you're genetically predisposed to type 2 diabetes, and a child is obese, if that child loses weight, becomes more active, type 2 diabetes can actually be prevented. So although there are genetic components, and actually type 2 diabetes is strongly genetic, you are correct in that it's also strongly environmental, and most important, it is preventable. Today we're going to focus on type 1 diabetes, which is most common in children. It is the most common type of diabetes that we see in children is type 1 diabetes.
Okay, but I think that the takeaway from what you've just told us and clarified is that if there are family members that have diabetes, we need to keep a record of that, your own family record. And we need to really know that that's an alert to have any other children in the family, observed, maybe tested at different points and just focused on, because the chances of them having some genetic component of this would be high.
Would be higher in type 2 diabetes, but certainly higher than the general population in type 1 diabetes.
Okay, very good. So for this show, we are not going to talk about everything with diabetes in children because we couldn't possibly do it in a half hour. So this show is really focusing on type 1.
That's right.
Okay, so tell us more about it.
Okay, so type 1 diabetes is a disorder that is seen in children and generally is seen, occurs in school-age children. 1 in every 400 school-age children has type 1 diabetes. And if you think about schools have about 400 to 600 children in general. Every school probably has, it's likely that has 1 to 2 children with type 1 diabetes. Type 1 diabetes is very labor intense. For any of you who have children with type 1 diabetes, you know that it's a very labor intense disorder. Blood testing is necessary. Insulin injections are necessary. So type 1 diabetes really does impact on the life of a child. And what we try to do as diabetes providers is to structure the diabetes care around the life of the child, not the life of the child around the diabetes care, because the goal is always for the child to live the most normal possible life, even having a chronic disorder.
Well, you told us that you were going to help us really understand the signs and symptoms, and tell us about those, and also when parents might start to notice them.
Okay, so that's actually an excellent question. So the common signs and symptoms of diabetes, and in general, but we're focusing on type 1 diabetes, are voiding large amounts of urine, because when the sugar builds up in the bloodstream, the way the body gets rid of the sugar is through the urine. So children are going to the bathroom frequently and voiding large amounts of urine. Because they're going to the bathroom so frequently, they're very thirsty. So they're always looking for something to drink, and they're also very hungry because their calories are being lost in their urine. Without insulin, and remember, children with type 1 diabetes don't make insulin, their bodies don't make insulin, the food that they eat can't be used for energy. Insulin is the key that has food used as energy. Without insulin, the food and the calories and the energy go out in the urine. So children who have type 1 diabetes, the early symptoms are going to the bathroom a lot, urinating a lot, drinking a lot, and being very hungry.
Okay, and what ages would parents start to notice that? I mean, at first those symptoms may be sort of subtle. You may not notice them dramatically, but then as they sort of sustain over time, you would then start to notice those things. Lots of peeing, really. Your child is always going to the bathroom. Being hungry, being thirsty. These are very cardinal signs, but at what age would a parent start to notice that?
Well, generally we see diabetes occurring in school-age children, and the diagnosis is easier in school-age children because the school nurse will call home and say to the mother, your child is asked 5 times in the course of the day to go to the bathroom. Your child is asked to be excused, to get a drink. It's difficult in the summertime, and we see a lot of children who come to a late diagnosis in the summertime because parents think, well, my child is drinking a lot because it's hot out, and they're peeing a lot because it's hot out. So we notice that there's sometimes delayed diagnosis in the summer. What is very interesting to talk about now, when we talk about at what age would we see children present with diabetes, is if we could see the graph of the Philadelphia Diabetes Registry. So I have maintained a registry in Philadelphia of children with type 1 diabetes, and a registry means that the children who have the disease are put into a database and put into lists. So these are children, when you look at this graph, incidence means new cases. So these are new cases per 100,000 children per year in Philadelphia. And this graph is focusing on children who are younger than the age of 5. And for the first 3 groups of the registry, so 1985 to 89, 90 to 94, 95 to 99, the incidence or the number of cases in very young children was very low. Very low. Rarely did we see children with type 1 diabetes under the age of 5. In the most recent published data, 2000 to 2004, and we're collecting right now the 2005 to 2010 data, the incidence has increased by 70%. So we've seen a tremendous increase. If you look at the bar to the extreme right, we've seen a tremendous increase of type 1 diabetes in very young children. And why this is so concerning is that when young children have the symptoms of type 1 diabetes, they're often missed. It's not a child whose teacher is calling and saying the child is going to the bathroom. Some of these children are not toilet trained, so it's difficult to quantify how much they're urinating. These children under the age of 5, are the sickest at the time of diagnosis. The highest rate of morbidity or illness, the highest rate of mortality or death at diagnosis of type 1 diabetes is in children who are under the age of 5. Often primary care providers do not think about diabetes in young children. So the message that I would really like to get out today for parents is that those kinds of symptoms, if you're seeing any child of any age drinking excessively, voiding excessively, it's important to think about diabetes. The other point that I want to bring up is that sometimes you may see a child who was previously toilet training start to wet the bed. And often the thought is, well, my child is drinking so much, so that's why they're wetting the bed at night. No, the child is drinking because the child is putting out a lot of urine and needs to drink. So if your child begins to wet the bed when the child has already been toilet trained, it's important to think about the possibility of diabetes.
That's very interesting, because I don't think many people would even give that a thought, or necessarily even ask their primary care provider about that. They might think it's psychological, or the child is regressing for some reason.
Sometimes children are punished for this, which is very sad, because clearly this is beyond the child's ability to.
So unless there was some really overt reason psychologically that a parent might be able to say, you know, I understand that this child is very upset about a certain situation, if it really lasts for any period of time, that child should be tested.
Definitely.
Okay, that's a really important point. I don't think most people would know that.
Definitely.
So even though you kept talking about school-age children, your graph really was talking about preschool children.
That's true.
So that is harder, as you pointed out, for parents to really recognize. So other than bedwetting, you know, post toilet training, are there any other things that a very young child could be doing that a parent could be alerted to?
Well, again, it is really this constant quest for something to drink. The child drinks something and then a few minutes later is asking for more to drink, or pointing to the refrigerator, or pulling the refrigerator open. The other thing is weight loss. So because children are putting their calories into their urine, they're losing weight. So you may see that your child is eating large amounts of food and yet seems to be losing weight. So any of those signs, it is very easy to test for diabetes. This is an easy test. So if you are concerned that your child may have diabetes, I recommend that you take the child to your child's primary care provider.
And tell us about the test. What is the test?
So the quickest test is a urine test, because the body is putting the sugar into the urine. So a dipstick urine test tells us if there's sugar in the urine. And if there's sugar in the urine, that is pretty diagnostic. It will also be followed up with a blood test to see how much sugar is in the blood. But those are the classic classic tests to make the diagnosis of diabetes.
Very good. I'd just like to step back for a moment and talk about this diabetes registry that Dr. Lippman put together 25 years ago, because she was educating me that very few cities in the United States have had such a registry. In fact, she was the first person to put a registry together. So she has, for the Philadelphia area, the most data than anywhere in the United States. So just tell us for a moment how that got started.
Okay, so I wasn't the first registry, but this is the Philadelphia registry is the only one that has continued since that time. So interestingly, this was my dissertation topic, and at the time that I started, and it was actually 1990, but the data were, we looked at the data from 1985 to 1990 for my dissertation. There were 16 cities in the United States that had pediatric diabetes registries. The Philadelphia registry is the only one that is still continuing since that time. So there were many registries when I started. Dr. Ron Laporte in Pittsburgh was really the father of pediatric diabetes registries and my mentor. And it became my life's work. I didn't expect it to, but it became my life's work, because it's so important to be able to identify changes over time in a disease, epidemics of a disease, and you cannot do that unless you have a registry. So of all of those registries that were being maintained in the early 90s, the Philadelphia Pediatric Diabetes Registry is the only one that's still ongoing.
That's really very admirable that you put that together and you sustained it. We don't have enough time to talk about why the others didn't get sustained, but how about today? Are there cities that are putting this together and moving forward?
Yes. So there are cities, there are a group of cities that started in 2001. None in the Northeast. So again, Philadelphia continues to be the only city in the Northeast with a registry. But there are a group of cities now that have a pediatric diabetes registry, started in 2001, but they have no data from the 90s and no data from the 80s because they just started in 2001.
Very interesting. Just as a comment, often people will wonder, like, why are nurses getting PhDs? I mean, what is the value of that? And I think this is an excellent example of what Terry was able to do with her interest. You know, she did it for her degree to get her PhD, but then she's really made such a substantial contribution to the health and wellness of children with this disorder throughout the whole metro area of Philadelphia. Given healthcare reform and all the emphasis on prevention, and you do need information in order to track these problems, what would be your recommendation for having a national registry for diabetes?
Well, I've tried to work very hard over the years for a national diabetes registry, for diabetes to be a reportable disease, because I do believe in many countries in Europe have diabetes registries, have national diabetes registries, and they have tremendous amounts of data, not just of who is diagnosed, but how children are treated, what the outcomes are, whether they have complications. And without a national registry, it really cannot be done in a comprehensive manner. So I have been working hard and will continue to work toward a national diabetes registry.
Well, I think it's really important, not just for children, but for even adults, because we do have an explosion of diabetes in this country. So we really do need to keep track of it. Are there other registries for other diseases?
Cancer. There is a childhood cancer registry that has been ongoing for a number of years, and tremendous information has been learned from that cancer registry. So I would always hope that the diabetes registry could use the cancer registry as a model.
Okay, so given the fact that we have been able to track that there's been this tremendous increase of type 1 diabetes for children under 5 years old in Philadelphia, let's get back to when parents do finally, take the child to the doctor is able to do the
or nurse practitioner.
Or nurse practitioner. Thank you for that correction. Their primary care provider. What happens then after they are diagnosed? What kind of treatment is available, and what is the parent's role in all of that?
Okay. So the treatment that is prescribed for children with diabetes is blood sugar monitoring and giving insulin, and also monitoring the diet, because the diet affects what the blood sugar is going to be. Any of you who are parents of children with diabetes, I applaud you. It is, as I said before, a labor-intensive disorder. And the children with diabetes test their blood sugars 4, 5, 6, 7 times a day, and depending on the insulin treatment that they receive, they're either getting multiple injections of insulin or they're using an insulin pump.
Mm-hmm. Okay. So you said earlier that there are some age-related challenges with this. So can you walk us through what some of those age-related challenges might be?
So it's very difficult having a baby, an infant with diabetes, or a very young child, because parents have to do blood sugars, and blood sugars can be painful. Parents are used to comforting children when they're crying. It's difficult to do painful procedures to young children. As children become toddlers and they want to explore their world, parents are concerned about children going and having babysitters, people watching their child. So the exploration of the toddler can be difficult. School-age children sometimes are very interested in showing their classmates how they check their blood sugars, how they take insulin, and sometimes are very reluctant to do so. So school-age children are sometimes uncomfortable being different in the classroom. If they need to eat a snack, if they need to check their blood sugar, this is a struggle for children and a struggle for parents, because they don't want to be look different. And that's even a bigger problem with adolescents. We all know that adolescents want to be like their peers. So adolescents often have a very difficult perspective, different perspective in terms of not wanting to be different from their peers, not wanting to check their blood sugars, not wanting to take their insulin. They also feel invulnerable for the same reason that adolescents will drive down the expressway at 80 miles an hour and believe that nothing will happen, or may drink and drive. They also may omit injections of insulin to see what will happen. So each age has their own struggles, and parents must work with children at all ages. Sometimes we have situations where parents say, my child is 13, it's her diabetes, and if she doesn't want to check her blood sugar, so be it. And my response to those parents is always, what if your child said that she didn't want to do her homework anymore? And the response is, well, she would have to do her homework. I say, look at diabetes as you do any other task that a child must do. A child must check blood sugar, a child must give insulin, this similarly to how a child must do homework and must go to school. So parents must supervise and work with children. Children take over more responsibility as they get older, but still there should be some level of parental eye and parental supervision.
Right, tough job, and I agree. You know, if you're really dealing with this, I'm sure it's extremely frustrating, and you probably need some support as well as your children. Your child they need support as well. But in terms of the actual administration of the insulin, tell us about how that is done today.
Okay, so most children are treated either with multiple daily injections or they're treated with an insulin pump. And if I could see, so this is an example of an insulin pump. There are a number of companies that make insulin pumps, but this is a catheter that's threaded into the abdomen, and the child or the parent can do this themselves, and the insulin goes in constantly. If the blood sugar is high, or if the child eats something, they must push a button to give themselves extra insulin. So the pump, the insulin that's going in constantly is background insulin. Our bodies are making insulin all the time, 24 hours a day. If we do not have diabetes and we eat something, our bodies automatically put out more insulin. For a child with diabetes, they need to either give an injection to cover the food that they're eating, or they need to push a button on an insulin pump. This is a system that works well, provided that the child or the adult who is managing the insulin pump is doing it correctly. It's not a magic bullet for diabetes. If you do not give insulin injections, diabetes will be in poor control. If you do not push the button on the insulin pump, diabetes will be in poor control. So it's really all about doing what needs to be done. And as I said before, it's labor intensive.
Briefly, tell us about the health disparities piece. Why would some people get pumps and others not get pumps?
So I have been part of a study that is national, and it's called the Type 1 Diabetes Exchange, and there are over 9,000 children across the country in that study. And we looked at children being treated with insulin pumps, and we looked at it by the race of the child. And white children are significantly more likely to be treated with insulin pumps nationally than are black children. What we often hear when we talk about racial disparities is that it's really not about race, it's about parental education, and it's about socioeconomic status. Because as providers, we worry that parents who are not highly educated or parents who do not have a lot of financial resources cannot cope with sophisticated treatments. So in this particular study, we controlled for parental education, and we found that even when both parents had master's degrees, white children were significantly more likely to be treated with insulin pumps. Even in families where the average income was $75,000 or higher, white children were significantly more likely to be treated with insulin pumps.
Right. Well, you can see that there are lots of challenges with this disorder, and I think what Terry Littman has helped us do today is to really understand the broad overview of this disease. There are many different components. There is the opportunity to sort of assess your own child and to look for those signs and symptoms. There is then the second step of going to the primary care provider and seeing about getting your child tested. It's then the management over the lifetime of this child into adulthood when they can really take up a lot of that on their own, that you will be doing a lot of oversight. I think the racial disparities is really probably a whole program in itself in terms of how we can really, mount that campaign and make sure that everyone is getting an equal opportunity to have the same kind of treatment options. So I want to thank Terry for this overview today. I think that we'd like her to come back at some point and tell us about type 2 diabetes and really be our expert in helping us to understand this very challenging disorder. So thank you for being with us today, Terry. It's been a delight to be educated by you, and I want to thank you for joining us. Thanks again, and have a wonderful day. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening, and join us again. And remember, with health, all things are possible.